Dr. Prado started it 25 years ago because people were dying. And the unfortunate thing is, even after 25 years, and the work that we've been able to put forth and incubate and be able to push forward, we still see that in the mainstream systems, the broken system is that people are still dying. And unfortunately, this is really it's a human issue, and this is an injustice that we're seeing to people across America. So it went from a stage 2 breast cancer all the way up to a stage 4 and a very aggressive, very advanced disease. And so I like to share this because this is where she had a referral. 60% of our patients are referred by other patients. And this was after 12 weeks of treatment. The patient, after going through our protocols, was a complete remission after 12 weeks of care. But again, if you actually are starting to see the actual total cost of care, and this is what I started going into, looking at payer models and being able to look at why in the world are we having the inability to have healthcare freedom when it comes to not just better care, better outcomes, but also the cost of care.
First, a quick word from our sponsor.
At MPB Health, we believe in empowering you with the knowledge you need before making any decisions about your healthcare. We're passionate about making healthcare accessible, flexible, and cost-effective. We've designed solutions that fit your needs and comprehensive alternatives that address your overall well-being. Our memberships offer a powerful combination of services. You can alleviate the burden of high unexpected medical bills with medical cost sharing. Forget the stress of navigating healthcare alone. Our concierge team becomes your personal advocate. They're with you every step of the way. They help find the highest quality providers and facilities, all at the fairest price. They'll even help track down the most affordable medications. Our memberships are a modern approach to healthcare. Talk to a healthcare advisor to learn more.
Welcome. Thank you for joining us. It's Thursday, time for the Freedom Hub Working Group podcast. We got a lot of things to cover in this one, actually, but let me start with some quick housekeeping. If you're new to the channel, and give you a screen share, show you where to find us on the worldwide captured internet, and that would be at yourfreedomhub.com. And everything tipping us towards enslavement or freedom, we're headed towards the freedom side, of course, and a good future ahead. That's because we're all working on good stuff to get there. Some good things here. I'll start with quickly your marketplace. We do have some good product services here, of course, starting with Charlie's empowering benefits, medical cost sharing, really good stuff, much better than traditional insurance. If you can do it, check it out. Highly recommended. More choices, save money. And then we have personalized supplements, work based on your DNA. Very cool. Cardio Miracle, really popular, even with doctors. I was surprised, actually, but it's got like rave reviews. And also, nitric oxide is something we produce, but this will help us produce more of it. And as we age, especially, it's important. And then we have a couple of other things, including cancer-ish vitamins B17, and we might talk about it later, but you can check it out because we'll be kind of covering that in the show. And then, of course, my pavilion solution. Now, it's about creating a better future, better healthcare, better foods, better everything we talk about on this show. And you can read about it. I have some good testimonials, and we are looking for locations now in the US. Again, we were ready to start building, and then COVID shut everything down, like many people who lost their businesses and everything else. I mean, thank God we weren't under construction when that rolled around. Terrible. And then over here on your media hub is where you're going to find our speakers, our Wednesday show, our Thursday show, and then we actually are listing them who's there. So we're playing with this new format, but you can just come over and see who's coming, and if you're interested. And you'll get things. We're going to be on Substack very soon. you will get emails with links, or depending on your what you're doing. So again, it's all kind of in the works. Our most viewed shows, if you're curious, who's like what the trends are, what's trending, maybe that's a better way to put it. And then our channels. Uh, Rumble is our kind of go-to channel. Just wanted to let you know. And then we also have BitChute, Brighteon, Tubi, another favorite, if you've heard of it, and YouTube. We've said we're not censored, but they're I think they're like opening back up because of the lawsuits that Trump and others have just won against Google, which owns YouTube. So we're going to try putting stuff back on YouTube and see what happens. Um, it's still a great platform. So even if they're jerks. So with that, let me stop the screen share, turn it over to you, Charlie, to introduce the topic and our guest.
Thank you, Jim, and welcome, Dr. Oertle from Envita. And our founder, Jeff Cantor, is on too, and he's been helping the Patients First Coalition with their efforts and events, including one we'll highlight today, coming out later this month in Cleveland. And just to set some context here, as we always do. So we care a lot about MAHA, and when not co-hosting this weekly Zoom, I'm lobbying for a pretty old health freedom organization going back to the 1950s, the original one. And I did have contacts at HHS and tried to influence their most recent recommendations. And we got some stuff in there, but we also did not get some stuff in there, including the ignoring of medical cost sharing. And while most folks are divided in the health freedom community between what RFK cares about, pollution of our air, water, land, food, and medicine, for years and decades, going back to my time as a congressional staffer, there always were people who really focused on health reform, health payment reform, opening up the supply of health care with scope of practice and licensing reform. And I'm trying to get NHF to combine the two, as is one of our guests today, Doug Benz from the Patients First Coalition. And the failure here I'm highlighting shows you why we need to think collectively with health freedom, not just the environmental pollution side, but also the health payment side and the supply side. And, you know, we also are probably going to lose on Obamacare subsidies. It's just too hard to see people lose our subsidies. When I substacked about this, I tried to highlight to people that there is an alternative, which we promote here at Freedom Hub, sharing. Unfortunately, very few of our conservative friends know about sharing. And this 10,000 deductible plan is going to be Trump's answer for the exchanges if the subsidies go away, which isn't a very good option compared to sharing. So this is the Substack from last night about today's event. And in the second paragraph, I do link to the last event that Patients First had this past July. Because what I love about the Patients First Coalition is they bring the cartel players, as I lovingly describe them, to the MAHA activists to see where we can cooperate and do some business. They have Shark Tanks, they have panels with MAHA health freedom types and with disruptors in the health payment space, which we bring together here in Freedom Hub and have done so for the past 7 years. Ultimately, we do hope you do register for the conference in Cleveland later this month. And Jeff, let me know when Doug or Shannon do arrive at the show so they can discuss that. Meanwhile, pardon me?
Doug's here.
Yeah, Doug, I mean, before I introduce Envita, would you agree with that that's sort of your niche at Patients First, that you're bringing insiders together with MAHA activists to see where we can do some deals to make money as we make the health system better?
Well, make money and also move the needle on health and wellness across the country. And we, what we've basically said is anybody who's willing to look at change is welcome, right? Because it's easy to look at each silo and point fingers at what's wrong and what's right, but we're looking for people that are willing to try and look at things differently and make solutions inside of everything that we're working with. And I think what was evident in Washington was that both sides of the equation, the good well-meaning people, I should say, I'm not talking about the non-well-meaning people, do want to have those dialogues. And I was seeing, Children's Health Defense Board members sitting with hospital system CEOs and talking about topics. And so I think that's one of the big things that we're trying to do is bridge the gap to fix what we can fix. And
And and I think, Doug, you would agree that today's guest envisions or encapsulates that combo, that integration, where Envita is using alternative therapies along with mainstream therapies to really have better outcomes on cancer and other chronic diseases. And all of us were amazed with Dr. Oertle's presentation and his team at the DC conference. And out of that came Lose Law, a project to see if we can't get insurance carriers, starting with the government carriers at Medicaid and Medicare, to start paying for more alternative treatments. And that is the subject of today with Dr. John Oertle. We're going to hear from first. Before he starts, Doug, do you agree that Envita kind of encapsulates that combination?
yeah, I do. And that's why we love the folks at Envita, and we were doing a ton of stuff with those guys because basically Dr. Prado and Dr. Oertle have said, look, anything that we can do to help the patient to get the best outcome. And they look at every spectrum from the far end of holistic to even the deepest traditional medical treatments. And nobody can argue with their outcomes. And I think it's an ideal microcosm of the direction that we need to go as a country. And so, yeah, I jokingly tell everybody I talk to virtually, they get sick of my hearing it, that if you ever have a family member with a cancer diagnosis, at least you should call up Envita for a second opinion. And that's, yeah, so I think they're a great example of that.
So, Dr. Oertle, that's the setup, and you can take it away. I think I pronounced your name correctly this time after I heard Doug say it. And maybe I'll use the German pronunciation, Oertle, if you like that.
Mhm.
But we're all excited about Envita, Lose Law, that integration of mainstream and alternative. It's an exciting time to be involved with the healthcare space. And take it away, sir.
Yeah, everyone, thank you so much for well, one, the introduction. Really grateful for that. And we really are. We began Envita 25 years ago because people were dying unneededly in the actual system. And so we are a center of excellence in Scottsdale, Arizona. But Dr. Prado started it 25 years ago because people were dying. And the unfortunate thing is, even after 25 years, and the work that we've been able to put forth and incubate and be able to push forward, we still see that in the mainstream systems, the broken system is that people are still dying. And unfortunately, this is really it's a human issue, and this is an injustice that we're seeing to people across America. And obviously, the system that is unable to pay for it, these subsidies being removed, and healthcare plans becoming more and more expensive. Again, we can't really fix the problems of society until we actually are able to um, until we're able to actually focus on the healthcare of our country, to be able to make sure that we're able to be able to really move the needle on patients' health. And so, really, where we looked at from Envita, I'll share some slides here to give some idea just about some of the work that we've championed over the last 25 years. We have 8 campuses. We've grown to now over 250,000 square feet of space. But this is where we were at our 2021, 2023 cohorts. We knew we were good when it came to the actual treatment of late stage cancers. And as people have alluded to here, we were really looking at our main model was not just having a preference or a prejudice to conventional therapies or a prejudice to alternative therapies. We really started because we saw this injustice to human persons and lives not being able to get the best technology and the best options being able to be delivered to them. And so as a result of this, we started looking at what is the best way to be able to produce outcomes to make sure that we continue to use the technology that exists to be able to derive outcomes and incubate this outside of the current system space. And so we had for years worked on cash pay patients to be able to receive care out at Envita Medical Center as we continue to incubate these actual treatment protocols. And this is where we have about 80% of our patients fly in from outside of Arizona. About 20% of those come in internationally outside of the United States to be able to receive care. But in our 2021, 2023 cohorts of patients in oncology and dealing with late stage cancer patients, we actually found that we were 35 times better outcomes than the conventional NCNN guidelines. This is your standard of care model of chemotherapies that are being prescribed based upon the tissue of the tumor types. And this is what your insurance companies, the big systems, are currently approving right now. And this is all done under this ability to be able to make sure that we are delivering care at the best possible way at this white glove approach and this concierge level. As we did this, though, we also ran actuarial data on our model to be able to see what was the cost of this care. And this was a number of years ago now, about 5 years ago, where we actually ran actuarial data to be able to look at, because we knew we were better, and our data proved it, and we published those papers on this. But then we also looked at what was the amount of cost. And so, to our surprise, we were half the cost of the conventional oncology system, half the cost. And so this is where we started going into being able to say, how do we actually change the system? We know our medical center is getting incredible outcomes for these terminal illnesses, for cancer, for late stage cancers, for early stage cancers, for other chronic diseases, really looking at the etiology and those root causes. But how do we do this in a way that's able to actually start to serve more Americans? And healthcare sharing, as Charlie, you were mentioning earlier, it was one of the ways that we started to be able to look at serving Americans across the country. Not all healthcare sharing organizations actually share into the actual work we do either, because they're more in this model of this, AMA, National Comprehensive Cancer Network, old paradigm model. But there are some healthcare sharing ministries that actually do share into the actual the services. But what we also started going into was actually how do we actually make sure that other groups, self and level funded employers, associations, how do we actually make sure that these other groups are having the same access to that level of care? And that's really where Envita Health was born, as far as how do you give, I like to say again, this precision model of care where care is really built around you. And so this is really our how we get those actual 35 times better results. I've got a couple of case studies here just to be able to give an idea with this. But again, I like to be able to share that when it comes to just a little education for the listeners, when it comes to the ability of this standard statistical analysis, one size fits all model that we've currently become so accustomed to in the conventional insurance and the actual conventional oncology and chronic disease model, is that it's this, I call it the medical insurance complex, is that industrial complex, is that again, there's not a lot of personalization to the individual doctor patient relationship and using the best data to be able to drive decision making around the actual patient. One of our data points that we ran in our recent paper was that when patients actually come into Envita to be able to get analyzed and get full diagnostics ran of the data on their tumors, the data of the DNA floating around in the bloodstream, circulating cancer cells that are floating around in the bloodstream, being able to actually analyze the proteins, the metabolic health, the immune health, all of these different biomarkers that we're able to actually run. When we did this, we actually found that 90% of our patients that came to Envita were being prescribed drugs chemotherapies that were one or multiple were already resistant to their cancer. And so this is where, it's unheard of that we still live in 2025 and we're not getting full data that exists to be able to actually evaluate, is the chemo or treatment going to provide resistance, or is it going to be effective for your actual the patient? And so as Doug was talking about as well, we utilize our chemotherapies, but only we utilize them when they're actually showing to be effective, and how we utilize them is very different than the mainstream to be able to obtain those results. And so with that, again, if you're looking at this, you really want to make sure you're using the right agents that are actually showing sensitive. One of the other things we look at as well is, how is the delivery mechanism of these agents to the actual tumor? And so I like to share with my patients frequently that the ability to deliver chemotherapies in an IV, only about 5 to 7% of chemotherapy gets to the actual tumors. When we actually look at the how we deliver our chemotherapies, we have a process called CIPI, chemoimmunoprecision injections, where we actually go in with a catheter the size of your hair and directly inject these actual genetically targeted medications directly to tumors to be able to actually get them to respond. So we get a 95 to 100% absorptibility into tumors. So this is where it's this thinking that we've developed these processes and programs to be able to really make sure that we're moving forward on the very best of outcomes for our patient. And so this is an example of a couple of patients that we ran. And so this case specifically, if you look at this, if you go to the right side of the screen, this was a 38-year-old female patient that came. And so she was initially diagnosed in January of 2023. This was with a stage 2 breast cancer. Okay. And she went through the full conventional care. She received her double mastectomy, meaning that she cut off both of the breasts. She refused some chemotherapy, but wanted to be able to go through the hormone blockades. She actually ended up then going through the removal of the ovaries to be able to go through surgical menopause at the dear ripe old age of 38, unfortunately. But then the unfortunate thing is that only after a couple of months, she actually ended up having a full body scan. And this was all the tumors, if you see all these little black dots in this actual imaging. And this is where, after surgery, after hormone blockades, that it still came back and was now littered throughout the whole body. So it went from a stage 2 breast cancer all the way up to a stage 4 and a very aggressive, very advanced disease. And so I like to share this because this is where she had a referral. 60% of our patients are referred by other patients, which I'm very proud of as well, who have survived and had a great experience with us. And where we were able to this was after 12 weeks of treatment. The patient, after going through our protocols, was at complete remission after 12 weeks of care. And now I say this too, because it's not just about the actual patient's life, but again, if you actually are starting to see the actual total cost of care, and this is what I started going into, looking at payer models and being able to look at why in the world are we having the inability to have healthcare freedom when it comes to not just better care, better outcomes, but also the cost of care. If we were to look at that patient from the time that she actually had that stage 4 cancer with those tumors littered across her body, they would have, again, looking at the conventional plan at that point in time, you would have been looking at close to or it would have been 455,000 just for that plan actuarially, based upon this actual staging type of cancer and when she actually came on in with all those tumors. If you look, we were able to actually do it after 12 weeks. Total cost of our care was 195,000. And we're very proud of this. This is where, when we're using direct tumors, we're able to use less chemotherapy. This also means reduction in cost. This also means less complications. This also means the ability of patients to be able to maintain healthy immunity during the course of care. But I love this because the patient's outcomes are why we do what we do. But then you also are able to see that what we're able to do is able to have an overall cost savings of 57% when it comes to, again, overall cost of care. This starts to be able to be a way, if you look at insurance, and that's just, again, is an example of one of the cases that we have. But when you look at insurance premiums continuing to be able to rise, this is one of the reasons that we actually see that 40% of the cost of that goes from an insurance company is regarding about 1 to 2% of claims. Most of those claims we actually see as well are in the fields of oncology, autoimmune, neurodegenerative conditions, and these are all things where Envita has specialized in to be able to actually make sure that outcomes are supreme, and then you also are able to do this at a root cause or at a reduced cost. I'll give another example because I love these cases because a picture speaks 1,000 words. This was a gentleman who was in 2017, was diagnosed with prostate cancer. It was an early stage as PSA started to be able to rise. Now, again, I just recently, last month was Prostate Cancer Awareness Month. If you actually look at, we just left it for October, now it's Breast Cancer Awareness Month, but last month in Prostate Cancer Awareness Month, I just did a piece that when you actually are looking at the evaluation of prostate cancer, not many men know this, but even if they get a radical prostatectomy, which means a full, complete removal of the prostate, which is standard of care, within an early stage prostate cancer, in 20 to 40% of the time, the PSA starts to be able to rise, meaning that cancer antigen, that saying that there's cancer present, rises within 10 years. So this is unfortunately the true removal of the prostate with a stage 1 to stage 2 is not fully curative, and in 20 to 40% of the cases. And I think this is important for men to know, because if this is not curative, then the PSA starts to rise. It's not fully clear. And then the unfortunate thing is with a lot of the actual radical prostatectomies as well, which is the removal of the prostate, even with a Da Vinci procedure, a Da Vinci is a robot. This is what causes it's more costly to an insurance plan, but it creates the similar symptoms. But men are dealing with literally leaking, that they have to wear literally pads or diapers over the course of the rest of their lives. Even 12% of men never actually stop that side effect from occurring, and they have to be able to now wear a diaper or pad for the rest of their life because of leaking. Creates pain, it creates scar tissue in the area. And so as a result of this, it also creates the ability of needing to have more surgeries, increased cost. No man wants to go through it. And so this is where, when you start to see this is where, what's the cost of a technical cure, at least in 20 to 40% of the time it actually returns. My point here is that when you actually are looking at more of an Envita approach, and when I'm able to say this one size fits all standard of care model has not been serving patients well, and we actually have better models of care. And this is where, too, I really fully believe that these models of care will be able to be available in the major healthcare system in the next 5 to 10 years. And yet, many times, a delayed care is oftentimes denied care because you're not actually getting the care that you need today, especially when you are dealing with cancer. Well, I give this example. So we have 2017, this man had an elimination of the ability of the removal of the prostate, radical prostatectomy. In 2023, he was in a good example. 6 years later, PSA started to be able to actually increase. PSA started to increase. And as you can see, this was his imaging down below on that right-hand side. This is where he started to come back, and we started to see that there is metastatic spread to the actual bony lesions. He's now in a stage 4 prostate cancer, severe disease, especially in that femur, that leg area. Severe disease, but he had cancer in his shoulder and cancer in the back of the spine. After 12 weeks of our integrative therapies and really this precision therapy to be able to say direct targets to knowing exactly what chemos to be able to give directly to where we're delivering them. Also being able to know exactly what adjuvants or supplements or natural agents to be able to give, because it's connecting one with the chemotherapy, directly working with those actual metabolic markers on the actual tumors. After 12 weeks, we were able to bring him into full and complete remission. Now, that's exciting. The life of this man is absolutely well worth it and just incredible. But as you can see over on the left-hand side of this actual slide, what I feel like is even more encouraging as far as this goes as well is that it's when you actually see the cost. This gentleman, if he would have actually went and received the care of the conventional system actuarially from an insurance company. His insurance company from the time that he came with stage 4 prostate cancer would have paid out $539,000. This is where we just had now the ability of being able to do this after 12 weeks. We were able to actually do this for 147,000. And so this was would have been a total overall savings of 73% for this individual. Yes, that's great, but it's also more important is that his life is able to be saved. Last case that I have for you, and these are cases that just ring true in my brain, that again, these are the injustices the patients are experiencing all the time. This was a 70-year-old man that came in and ended up being referred out to be able to see us because he had a friend, again, in a similar place that responded incredibly well to care. But he was a 70-year-old man who he had received care in the conventional system, and he continued to be able to progress. And this was in May of 2022 when he was diagnosed. But in August of 2022, he was referred to hospice by his local oncologist because the cancer was too aggressive, and said that you may not make it, you may not even be able to make it past Thanksgiving of 2022 because the cancer is so advanced. And if it was me, I wouldn't actually go through additional care, which has been ineffective up until this point anyways. And let's just, again, I'd recommend going to hospice so that way you can have a better quality of life. This was now he came on out to be able to see us. I always like to say again, we ran data, we ran our analysis on him. And as we could see that he had incredible targets to be able to treat, we were able to support him with the right chemotherapy targets, the right immunotherapy targets, the right natural targets, the right ability of diet, lifestyle, exercise. And then within this, again, 8-week treatment plan, he came and he was completely in full remission after the 8 weeks. And this was so beautiful to be up. And this was in May of 2022, where his oncologist back home was saying, this was in August of 2022, where his oncologist was giving him a prognosis that he may not even make it past Thanksgiving. The beautiful thing about this is that he's still alive today, and he's doing incredibly well also. But this is a gentleman that what I love about this is the cost savings. So even if they were to be able to do the conventional care, it would have been about $948,000 to be able to do the actual conventional care. We were able to do it for $150,000 over those 8 weeks, a total cost savings of 84%. And so this for us is, again, yes, it matters because of the fact that lives are worth it, and that their lives are not being lost in having injustice to humanity being caused by, again, not having the freedom to be able to choose the care that is data based and data driven, and being able to actually choose this sexual system. And so this is where we started to be able to go into employer groups and healthcare sharing ministries to be able to serve other ministries and care. And what we've been able to do as well is being able to develop on the actual, this, just like we do with the best of technology, to be able to deliver medications to patients through our Center of Excellence. We started to be able to do this to be able to really make sure that this technology is being delivered to, again, third-party administrators for insurance plans. So now we have technology that plugs on in to be able to actually look at these intercepts, to be able to catch people early and give people a real choice to be able to, this is what Navimatrix Pro is. It takes claims data, RX data, your pharmacy data, takes your actual medical record, and it actually plugs it through our system to be able to actually plug into the adjudication platform from an insurance perspective, or a self-funded or level funded third-party administrator that's adjudicating those claims. And we are able to take that to really make sure that these plans are being managed effectively. And so we reach out to the people that we manage these lives under, to be able to make sure that we're able to give options, this true medical freedom, to people to know that there's other options that do exist in their healthcare plans, to be able to make sure that we're able to actually serve these individuals. And it's us that we send them to. There's other practitioners across the country that we send them to. A good example of this is that even if you have, say, for instance, mitral valve prolapse, we're able to send to an interventional radiologist to be able to put clips in the actual mitral valve instead of actually being offered open heart surgery to replace the mitral valve, to give an example. There are practitioners across the country that are doing this at a fraction of the cost, but also the patient, instead of having open heart surgery and 4 weeks in the actual hospital, along with physical therapy and all the trauma going through open heart and recovery and the risks of reinfection and the costs that accompany it, you're able to do this for a fraction of the cost, and the patient is able to leave the very next day, doing it with a catheter the size of your hair, going in through a vessel and being able to go and repair the mitral valve and then come on out with a Band-Aid. And so this is where these are options that exist. And it really is one of these, that it's this ability to be able to navigate patients. And we are in it to be able to make sure that patients are receiving the options necessary. And so, yes, this is where there's a lot of medicines and treatments that are already in existence. It's the ability of putting these things together and being able to make sure that patients and Americans are able to know about this and drive to these better options, so we don't just keep, again, going with this stream of the medical insurance complex that continues to be able to just escalate premiums and escalate care. But now, again, for us, it's really about being able to truly manage and to be able to provide these medical freedom options to people in these healthcare plans across the country. So that's what I got for you today. So I thank you, everyone, for the listening. But again, we're here to be able to keep fighting for patient freedom and for patient outcomes.
Okay, yes, great presentation, Dr. Oertle. It makes me think maybe leeches would be better, right? In some ways.
I saw you say that. Yeah, it is. I know it's tongue in cheek, but I mean, being able to give chemotherapy when you know it's resistant is just it certainly is a practice of insanity.
Yes, exactly. The other thing I was going to say, health aware. You're talking about We have breast cancer month. We have this month. How about like health awareness month, right? Something. Hello,
Or
nutrition.
at least opportunities to talk about prevention. What can we do to be able to ensure that we're able to actually empower individuals to be able to actually know how to actually prevent these diseases from occurring? I mean, our goals, even with the ability of finding now, and this, I didn't share this, but it is really encouraging. Yes, we want to be able to treat disease, but early detection and prevention is where you go to be able to actually remove these actual issues. I mean, how many times I know with Maha and Bobby Kennedy, I'm a huge supporter of being able to remove these herbicides, pesticides, carcinogens. But when is the last time an oncologist has ever, even with an early stage breast cancer, ever actually asked the question of, well, what potential toxic exposures have you had, and running environmental toxicology analysis to be able to actually evaluate? Guys, we're running this, we run this on everybody. We ask these questions. If there is a patient with over 95 percentile of a toxic pesticide that's causative of breast cancer in the data, guess what? That's pretty clear to me. We need to be able to remove that out. We need to remove the gasoline from the forest fire so that we can have an effective treatment on the forest fire. And yeah, you can actually treat that stage 1 breast, but let's make sure it doesn't come back again. Let's make sure it's not producing these growth factors and continuing to cause additional, again, return of disease. Or if you're a stage 4 breast cancer patient, you want to be able to remove that so you can actually survive. I mean, this is not even heard of in the conventional oncology model. I think it's because a lot of it, insurance companies are not actually covering it. So doctors aren't running it because insurance companies aren't doing it. Or what do you do when you actually identify that this toxin exists? Well, in these alternative integrative models, there's actually a lot that can be done when you actually evaluate this. But in the traditional hospital system, there's not much that can be done for a pesticide 95th that's identified in a 95th percentile in the tissue.
No, because then people will start getting better. So sorry, I don't want to. I do have one quick question. Turbo cancers, right? We're hearing that the jab back in 2021, whenever it started, has created all kinds of turbo cancers. and really is promoting tumor growth. I'm wondering if you're seeing that, or if you are, is there a difference in how that's treated? Is that like gumming up the works,
Yeah, it
or
sure
what?
is. So yeah, so so real quick, I mean, we've been seeing an increased rise of cancers, even young people cancers, less who are younger than 50 years old, throughout the course of these last 20 years. Okay, so we've seen this from about 2010 to 2020, it was about a 2.4% rise in cancers, especially in young people. So it's been ongoing. And then once we started to see 2020 hit, we started to see an exponential growth curve of these young cancers and turbo cancers as you talk about them. And yes, we have seen correlative data, and we've run data on what are those actual molecules that are likely to exhibit in the actual tumors when there has been an injection of a vaccine that has then led to, within a couple of months, of a cancer either returning or a new cancer to be able to be developed. But again, it's gone really aggressive. And the genetic markers, or these actual proteins on the actual cancer, are growth factors. So you can either have two things. One, you can have a cancer gene that is a braking mechanism that goes away, or you can have genes that upregulate the rapid growth. These genes, they upregulate rapid growth. So this is where even the data is suggestive of this idea that we've seen empirically of turbo cancers. Now, the other thing that I will say too is the fact that it's not just the vaccine that is carcinogenic. It's also the virus itself. COVID is carcinogenic. I've seen this. And we start to see it that, again, even people that have had long COVID that do not fully eradicate the actual virus, because the virus can continue to replicate in the tissue, especially the GI tract. We see this very consistently with the actual GI tract, pancreatic cancers, um, uh, the colorectal cancers again. But you start to see that there is an increase in young people with these cancers, but they still have the virus that's still replicating even months to years after they've actually had COVID, that it's still happening. And so this is where too, the health is in the immune system, especially when we're talking about cancer health, autoimmune health. It's in the immune system, and when we're dealing with an infection that is suppressing immunity or having hyperinflation of the actual inflammatory responses, you start to be able to see this inability of the immune system to be able to, one, remove the actual infection, which is the cause, and you have the ability to be able to, we all have cancer cells and mutations happening on a daily basis in our system. And then, but our immune systems, when it's functioning well, is able to recognize it and remove it. So the health, long-term remission, health and prevention of cancer is really found in the immunity.
Yeah, thank you. Okay. So you're having luck with them. I mean, your programs are still pretty effective.
Well, yes, they are, because you have to treat the actual that gasoline. We're going to run and evaluate this. It may be that, it may be that plus a couple other things, but we're going to evaluate that because it's a critical piece to the actual ability of taking that gasoline off the forest fire, so you can better treat that forest fire.
Got it. Thank you. Okay, question. We have Charles Ford. You're up first.
Well, thank you. This has been outstanding. I want to share a personal story briefly that involves Envita. My best friend's brother has stage 4 cancer and was told by the Cleveland Clinic that basically go home and die. So I heard about Envita with this earlier seminar we had about a month ago, and I did not think that he would be willing to go outside the box and go out to Scottsdale, but he shocked me and did. I received a very good prognosis. They've said you don't have a fast-moving cancer, it's a slow-moving cancer, in direct contrast to what Cleveland Clinic told him, and that he didn't need to go home and die. And they wanted him to get several tests run, and then they would begin a course of treatment. Now, I don't know because I wasn't present, but it would seem to me that he was also what I've been told that he was told, and that's hearsay, that he could get those tests done cheaper than you all could do. And if that is an accurate statement, then that's something you might want to look at. So I just wanted to say that. The next thing is somehow, some way, you've got to get to Kennedy and to Trump. I mean, he just announced this week, I listened to it because I'm retired and I have the time, that he's going to spend billions on AI to go after childhood cancer. What a waste of resources. What a tremendous waste of resources. You guys have pretty much got solutions to a lot of it, and what you don't have, it's just a matter of further investigation and development. Somehow or another, we have to overcome that and get you in front of those people. And I'm certainly not the person to do it, but I think that should be a top priority. The next thing is cost. Man, it's wonderful if you have a TPA and you're an employee and you got a self-insured plan and you're going to lower the cost from 450,000 down to 190. That's fantastic. In fact, with your permission, doctor, I'm going to connect you to a man that owns a large TPA in Oklahoma that is a very independent thinker, and I think they could lead to good outcomes for both parties with your permission.
Please.
The final thing is that let's look at Medicare for just a moment. I'm stuck with Medicare. I'm in that gulag. I don't have $200,000 to pay you to treat a cancer. We have to overcome that because Medicare is going to be the source of a lot of cancer patients, and that's something that's an opportunity to grow what you're doing into something that can become nationwide very quickly. And look at the cost savings. I mean, just look at the cost savings, what that have on the American taxpayer and the Medicare system. So again, that should be the second conversation that's had with Trump and his people and whoever and whatever. And Charles, if you can do anything about it, go for it, man, because this has got to be done.
So,
The last
guys,
thing is that,
this
go
is,
ahead. I'm
let
sorry,
me
I'll
interrupt
stop.
you for a second, Charles. That's
Yes.
that's exactly what Lou's law is set out to do, to allow Medicare patients to have access to therapies, alternate therapies, including Envita. We're working on that legislation right now to get that done. That's the driver of Lou's law.
That's
Yeah,
fantastic.
that's exactly right. Let me share that because Lou is a
Yep.
patient of mine and incredible woman. She's doing great now, but this is literally this ability to be able to gain access from Medicare, to be able to actually fight this, to actually have the medical freedom and the ability to choose where do you go, and being able to have access for all of everyone that's on Medicare to be able to actually receive the freedom to choose. If you want to come, you can receive it, as far as this goes. But that's really what Lou's Law is designed to be able to do, and we're seeing some good movement on that team. So connect with Shannon on that, who's kind of spearheading that Lou's Law movement. The other couple of things, if you don't mind, just going through your other questions. One, first question about the actual cost of the labs. I don't know if it's actually better cost as far as that goes, getting them elsewhere. I'd have to look at that because again, this is where I've seen. I doubt that there's probably saying that it's better cost, but it's not the same tests as far as that goes. So I'd like to be able to actually see that because I don't buy it. You see a lot of people in the actual healthcare field like to be able to say, well, I'm doing the same thing. Unfortunately, they have actually limited knowledge of what we actually do and how we do it. And so as far as this goes, it's usually not the same thing. And even if they're running maybe some genetic testing, it's not the extent of the genetic and the actual proteomic and the transcriptomic data that we actually run. So that's the first thing. Another thing, you were talking about the pediatric cases that Donald Trump and the actual administration are discussing. I 100% agree with you, but it goes to a deeper issue with our pediatric cases. The concern that I have is that there's too many medical hijackings because when you're a pediatric, you have CPS that gets involved, and then you're actually not free to be able to choose with medical freedom. And so there's too many medical hijackings that happen in pediatrics. And so I've had number of stories where we've been treating pediatric clients. We've actually been getting them into remission. And because of the oncologist back home that's done malpractice to the actual patient, and was concerned about his own liability, referred the father. One of the examples specifically is referred the father to CPS, who is a pharmacist and who wanted his son to be able to receive this kind of data-driven treatment. And anyways, we ended up having to send the patient back to the actual hospital because of CPS, and the patient was now ended up passing away as a result of progression of disease in the conventional hospital system. So these are cases that do occur. Again, it's we need to find out if we're dealing with pediatric cases and the ability of having medical freedom protections against these medical hijackings. And then I forget the last one that you actually said, but those were at least at the top of my mind.
All right, let's,
Thank you.
we got a few people. Let's go to Dr. Montalvo.
Dr. John, thank you for the presentation. My question to you, I got a couple of questions. One, isn't there a better test than PSA test? Because even Dr. Ambling, who was developer of the PSA test, says it wasn't for prostate cancer. It was for inflammation. That's one question. And then the other question is, especially indicating for prostate cancer, all the patients that you pretty much showed was 70 years and older. So when they came to you, based on my information and dealing with cancer myself, typically an older man will die with prostate cancer than from prostate cancer. So these metastases that you were dealing with, wasn't it caused by the very chemotherapy and radiation they were receiving in the conventional hospitals?
Yeah, it's a really good question. So let's see. The first thing is there a better test than a PSA? 100% there is. I'm giving PSA as a general description because this is what most people are running, and population health is actually running. I see that you're saying the prostatic acid phosphatase. Yeah, I see that in the comments, the PAP. That's one of the other ones as well. But there's other much better indicators as far as this goes too of prostate cancer. And there's some things that we're doing even regarding even liquid biopsies that are incredibly efficient to actually look at the actual analysis of, is there cancer DNA and circulating tumor cells and vesicles floating around in the bloodstream, to be able to actually analyze for various testing. Some of these, again, some of the ones that people usually know about that are even looking at other, multiple cancers, like the Gallery or the Grail test, as far as this goes. All of these are okay, but the ability of actually having false accurate responses are less. So I would say that there's actually even better testing than that. But this is where, yes, PSA is kind of not the best. It does have some correlative value. So it's not a absolute worthless test. It's cheap. It's what our public health system loves to promote. But again, there are definitely better tests than that. Oh dear, what was the other questions that you had for me?
The gentleman that you showed in terms of showing they were 70 years and older. So, based on studies that we've done for 30 years now, most men will die with prostate cancer, not from prostate cancer. So the men that you were treating had metastasis. Was not that caused by the conventional therapy with radiation and chemotherapy? That was
highly likely. For, again, this is where there are specific, a small amount of men that actually do have these genetic mutations with even when they're first diagnosed, that are eliciting an aggressive prostate cancer. It's almost a prostate cancer that responds more like different cancers. But traditionally, again, and this is over 98% of the time with men, they have prostate cancers that are slow growing, that you're having to induce more of like you're talking about, radiation, chemotherapy, that actually turns more mutations instead of actually treating them. So again, chemotherapy is carcinogenic. So this is where you even hear my patients talking about chemo in, chemo out. I want to be able to get the chemo to do the job that it's designed to do to the cancer, but then remove it out of the system. This is where, when you directly inject it, you're able to actually get the chemo directly targeting the tissue instead of actually allowing that actual chemotherapy to spread where it's actually carcinogenic to other tissue. So 100%, I do think that is very likely as far as that goes when it comes to these other men receiving these more traditional therapies. But you also see, like I was going to go to as well, you have population statistics, and there's, even in the African American men, you actually do see a higher likelihood of those genetics that actually do create more of an aggressive spread of prostate cancer, even when you're 70 years old. So it really depends. This is one of the things that I've continued to be able to learn that always surprises me, is that cancer is so highly complex that, unfortunately, when you deal with it, as far as kind of what we've been dealing with as far as this population studies or just another statistic, the problem is that if you don't run the data, we just don't know. And that's where even, we can think about it highly likely as far as that goes. Certainly radiation is, destroys immunity and it starts to be able to create mutations. High dose chemotherapy is certainly destructive to the body. And chemotherapy is not even as effective against prostate cancer half the time. But it is one of these areas that it is important to be able to know the data so that data is able to drive decision making. And unfortunately, it's when people don't have even access to that data to be able to make decisions. Well, now that's a huge problem I see in our society.
Yeah, one other question. Is
Hey,
cancer
John.
just indulge me one minute. Is cancer a metabolic disease or is it a immune system disease that turns metabolic?
It's so fun. I'll just say, I laugh. I'm laughing only because it's both. It really, you can't separate. Yes, is it a metabolic disease? 100% it's a metabolic disease. You have some cancers that their metabolism is literally driving the actual disease process, but it's also the epigenetics of the actual cells that are driving those actual metabolic nature. And so you do have mutations. There's also, is cancer a genetic disease of that? If you have cells that are, if you have two, if you have P53, which is the breaking mechanism of the cell that's broken in that actual cell, that is at higher likelihood if you have one of two of those actual genes that are broken. Well, then you have a higher likelihood with the metabolic nature, with chemotherapies, and with other um, uh, 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 herbicides, pesticides, solvents, phthalates, oncogenic infections that allow for there to be more of this metabolic push or issues with the mitochondria and issues with the cellular structure itself. And so I guess I don't want to oversimplify that because it's both and instead of either or. And I find it funny that people actually start to try to argue those things because both play a role in the actual treatment and the development of cancer.
Thank you.
I'm glad you mentioned CPS. That just drives any self-thinking person bonkers that our taxpayers fund an agency of goons that wreck families and kidnap kids for political decisions of independent thinking. So we've had plenty of experts over the years present on that dynamic, and we shouldn't forget it. That's just diabolical. If anything should be put in front of RFK and Trump, it's muzzling CPS, which I think starts with repealing Hillary Clinton's federal matching funds for foster placement, which goads the diabolical incentive dynamic inherent to CPS, and then getting rid of that subjective standard they have to arbitrarily ruin someone's lives. So my question for you is on the sharing plans, which should be more widely known as an Obamacare alternative that's better. No networks, no adversarial claims resistance, more affordable. Which sharing outfits have you found to be more amenable than others to not only your alternative for cancer and other chronic diseases, but just in general? And then follow up, Doug Benz. What kind of more well-known speakers do you have so far, or breakout sessions do you have planned for the conference that kind of follow along in this kind of vein? Go ahead, John.
Yeah, so I actually will refrain from speaking just healthcare sharing in by name. I just want to be respectful of the industry because I believe in healthcare sharing. I believe in healthcare sharing ministries that are able to actually, so it's member to member sharing. For anybody that doesn't know, it's an alternative to conventional insurance. And it is not insurance. And I love this because, again, it is absolutely not insurance, but it's a community of members that come together to be able to share one another's medical bills, depending upon their agreed upon community guidelines. And so all those guidelines are a little different. And I encourage everybody to do your own work on that and your own information on that. But what you tend to find is that they are, because they don't have the middlemen cost associated with them, they are much more reasonable as far as cost wise. The beauty is that you've mentioned, Charles, is the fact that, or Charlie, is the fact that, again, even things like open networks and they don't have networks. So you're not closed to this. Well, I call it the emperor with no clothes, this network game that the large insurance companies like to be able to pull, or the ability of being able to have. I always say this too, as far as something as simple as, so if you're a CEO of an insurance company and you know that you're contracted with a provider who's providing a nasal polyp surgery at $90,000, and you've got information that you have an insured going to this actual provider because you're contracted with them for that $90,000 procedure, but you know that there's another procedure that is actually being done in your local area for 6,000. You can't direct and move somebody to navigate to that actual better provider with better and that has better results. But with healthcare sharing ministries and these other self-funded level funded plans that don't have networks, you can drive people to better cost of care. And I always like to say, it's not just better cost, it's better outcome. I don't want you to go because there's a contract that that you can't navigate the ability of a patient to be able to go to somebody else because you're contracted with that person, that doctor, saying that you won't compete and navigate somebody away from them. And this is just these are things where, because of the system is broken, now I can't even advocate for an insured to get better outcome, cheaper care, which everybody wins, because of a contract that's in place by my network. And so this is where, when I look at these systems, there's a lot of brokenness as far as reasons why, but people just don't understand, or don't even know, or can't even be communicated that knowledge with transparency to be able to say, you need to look at Dr. Jones doing this procedure for $6,000 instead of the actual guy that you're going to that actually doesn't have as good of outcomes, and he's not doing as many procedures, and he's charging 90 grand for it. I mean, this is insane what we're dealing with. So that's where healthcare sharing ministries and organizations are really the opportune ability. They do. Thank you, Dr. John. They do make millions off of each other. It's insurance companies. You got that right. Insurance companies are scratching the backs of other large hospital systems that are actually covered by them. I do agree. There's a reason why cost savings from an insurance company is never what they actually are looking to do, or providing best outcomes for patients are never the actual benefit. They're only responsible for their own stakeholders, and they scratch each other's backs. I get that. But it is one of those areas where health sharing ministries allow for more innovation and better options for people, all at the same time being able to provide cost savings. So Charlie, thank you for the question, but I encourage everybody to look into them, because I want to make sure that you're making good decisions for yourself and what actually is the best value for what you're looking for.
Good
Doug, do you
answer.
want to?
And Doug?
Yeah, so quickly on the healthcare sharing point, National Healthcare Sharing Association is helping support this conference with speakers and panelists, and they're also about to start recommending that all of their member organizations work with Envita, something that we're working with Ryan and Brian and their team on, just starting now. As far as the conference goes, I will tell you there'll be some very interesting announcements. I will let the cat out of the bag a little bit. You were talking about, Breast Cancer Awareness Month. We're actually going to encourage the president and the secretary to make January Preventative Health Awareness Month, and we're drafting an EO to that effect that we're going to present to them, and hopefully we get that done.
Let's go to Liz James.
Hey there. Thank you for taking my question. So doctor, I'm the founder of Blessed by His Blood, and we match blood donors and recipients for people who've chosen to abstain from mRNA technology. We're also very active in legislation, trying to get protection for this. And you're very right about CPS taking children away, even for asking for things such as safe blood for kids. We've had that happen a few times in the last couple of years. But the question that I have regarding Envita is, what blood components are you using to ensure that your patients are getting something that's not going to turn around and cause a different type of cancer later. ASIP recently was presented with a slide deck that showed pretty unequivocally that the blood components, at least up to 23 months, probably longer than that. That's just when the studies have stopped. But the blood components are carrying in the potential of cancer causing agents as well. And that extends out into, the biologics as well. But I'm just
Yeah.
curious about the blood components that you're using at Envita.
Yeah, Liz. So one, our goals are trying to be able to prevent any type of transfusions from occurring in our patients, and many times we're
Okay,
successful in that.
good, good.
Second thing, though, is because we're not using our high dose chemotherapies, right? Again, the things that are actually so commonplace in your conventional oncology. However, what states are you in? I'd love to welcome you into Arizona. I am working right now with state legislators on a bill specifically on clean blood here in the state. But certainly, I am happy to
We
be able to work
we're
together on these things.
Yeah, we're nationwide and we're working on legislation nationwide. So we have members, and we are 100% not for profit. Like, nobody gets a salary. But I would love to talk to you about legislation and getting connected with a legislator in Arizona who would help us push this bill through.
I would love to, yeah, because we're certainly I'm working with them right now for this next legislative session. So yep, just let's connect
Uh,
offline and yeah, let's touch base
okay. Hey,
because I'd be happy to be able to work with you and even be able to see what you're able to offer for blood products here in the state of Arizona to be able to utilize them. So
okay.
there's a bit of a cap.
Peggy,
There's a bit of a monopoly on the blood market here in Arizona. So again, we when we do we try to treat it, we do things like even with irradiating the actual blood to be able to make sure that it's clearing out any of those infections that are still not seen. We treat it. We actually have protocols when our patients go through treatment and receive a blood transfusion in the rare chance that they do, that we're treating them effectively for these actual pathogens or M spike proteins. So but yeah, I would love to be able to talk to you about that. It's just hard to be able to actually have it. So
Super. Okay, well, we are like out of time, but I see Cynthia's hand is up. So yes, let's go to Cynthia Cox for that last question. I don't think I hear you. You're muted. You're muted, Cynthia.
Right. I said it's a shame we're out of time. I have some pretty heavy hitting things I want to raise. So let me just go through them quickly. I'm sure you're going to be back on because maybe I'm going to plant some seeds for you. So, some of us here on this, we're pretty radical. All right. So I follow the people right out of Germany. There's no such thing as a virus. Cancer is parasites. So, what I guess I want to hear from you is if some of this is possible, how the work that you're doing might help us uncover this, if you were ever to entertain some of these ideas. And, there's some interesting work being done. There's a doctor out here. I'm in the Wilmington area near the Amish, and there's a big heavy hitter who left U of Penn, and he's treating all the Amish with parasite medication, and he's having some pretty interesting results. Okay. And so that's not to say that, could cancer be a parasitic origin that goes totally, crazy. And so what you're doing can still treat it. But so I guess that's more like the origins of it. And then along with that, when you mentioned the COVID, you kind of lost me a little bit with the idea of a virus, because I think most of us here I don't want to speak for everyone, but we realize the Department of Defense's engagement in this. And so they developed the countermeasure. So the original thing was probably the same issues. So along with that, do you know the work of Dennis McKenna at MIT?
I do. Yep.
And so SV40, right?
Yep.
This is way back monkey, and in a way you could look at this as a parasite, okay? So how can what you're doing help us coalesce and get to the truth of some of this? Because we're all on the same page, right?
That's right. Yeah, I find all of these things to be really fascinating. And when I'm looking at it, it's when I'm looking at all of the different ways in which these cell products are are signaling. And so even when I, please forgive me on that. I understand what you guys are talking about as far as that goes, and there are different dynamics of how do these presentations of cancer, how does it signal? Because this is when I'm looking at it, it's looking at it under a microscope, looking at the signaling. Again, I'm not looking at an actual virus. I'm looking at the actual signaling coming from the tissue that's been disrupted from these actual from the etiological root causative factors. So I this is where my laboratory I think is would be helpful. I've talked to a lot of people in the actual in that space to be able to say how do you actually prove or look at these correlative measures of what we actually do so that the ability of actually seeing how is the epigenetics of these cellular products moving. I would say probably on the and even things like I know there's been the discussion of who was it that actually said cancer was a fungus or cancer is parasitic. I mean, all of this is just these models of how do you evaluate it. Again, I would say that there's definitely parasites that these foreign organisms, these oncogenic infections that actually cause the tissue to extrapolate, grow. But I would say that again, even this is that, this is, you want to know how this biological material continues to be able to grow and spread. And that's what I'm looking at in my laboratory is to be able to actually evaluate what are these actual epigenetic, specifically RNA, proteins, and metabolic factors. How are they interplaying with the actual patient to be able to deliver the right product? There are anti-parasitic medications, obviously fenbendazole, membendazole, ivermectin. We've been using these for years, and this is where it was I've been using ivermectin. Well, this was back a long time ago as far as that goes, pre-COVID, as far as this, and know that it actually has that benefit. I'm grateful that there's been a raising of awareness of what it's doing for cancer, specifically with immunotherapies and supporting the actual body to be able to recognize these actual tumors. There's specific mechanisms that ivermectin or fenbendazole or membendazole are using, but it's one of these areas that we utilize it when the signals are showing that there's a correlative match to be able to actually prescribe those therapies, is how I utilize it. But I'm happy to be able to take that offline as well and kind of deep dive on my philosophies and theories about all of this. So
Well, what I think is just let me finish because what I think is so exciting about the potential of what you're doing then is as you are gaining greater clarity and understanding of what you're seeing, you actually may be able to help us define this a bit more further, right? I mean,
correct. Yeah.
because you're
Yeah.
aware
So
of
I get to, I
right,
get to,
right,
yeah, there's
right.
the ability, and this is what this is not this is not the first time I've had these conversations with, I won't share who. And if you ever want to come out to Envita and tour our facilities and evaluate it, we've had a number of the, well, again, the freedom fighters that have been out and discussing these things. And so the laboratory is really where I think the most help is really at to be able to look at these correlative dynamics of what's actually going on from a laboratory perspective. Um,
Great.
I'm
Well,
getting here. Interesting. Ivermectin and fenbendazole seem to work. This is Mark. Yes, fenbendazole and ivermectin do have a place, and they do work. I would say that it's not what I've seen in my clinical experiences. Even people that are on them are on the right dosages as well. Let me just say that I think ivermectin many times when I see patients are under diagnosing or under prescribing dosing. Um, and so you want to make sure it's the right dose, the right way to be able to treat it. But it does work. But at the same time, it does still have limits, because I see many people now, even, even after the last number of months, people are many times having cancer and on it already prior to coming and seeing us. And we're still seeing progression. So there's more that many times needs to be done, than just fenbendazole or ivermectin. But again, it's definitely many times it's a good and helpful thing for people.
Thank you. We are done, I guess, pretty much. Clock has run out. Dr. Oertle, how can people reach you, follow you, and maybe we're going to have you back in 6 months with something from the lab, and we can talk about some of these. Is there a virus, or how does the signaling work? Whatever it is. But in the meantime, you guys are doing great work. Why don't you share at least your website again, or anything you think people would want to know about, or look you up?
Yeah, great. My website is envita.com, envita.com. Our health plans and programs are found going to be on envitahealth.com. And then if you want, feel free to be able to email me. I'll provide my email on the chat. I've already provided it on the chat, but you can feel free to be able to email me as well on the chat. And I'll put you right with the right people and the right people on our team. So,
Doug, why don't you kind of build on that with a quick kind of summary of what folks can expect in Cleveland at the end of the month in terms of innovators like Dr. Oertle who are really integrating the system, giving us the combination of mainstream services, but also natural, and how from payment to delivery, that does serve as a common theme of some of your presenters and breakouts and Shark Tanks and whatnot.
Hey, Doug, or Charlie, I can also put up the Join Us in Cleveland PDF if you want to see that. People can, while you're talking, they can also get the QR code. Yes, no?
Yeah,
Yeah,
fine with me if
pop
you want,
that
Jim.
open. Yeah,
Okay.
pop it open, Jim.
So
I
for
texted
those,
some links about some of the topics too in the chat. Go ahead, Doug.
so I think for those of you who were in Washington, um, you experienced something pretty special. I mean, the biggest thing that happened in Cleveland, I mean, in Washington D.C., was the number of relationships that were built. I mean, and the cooperation and the bridges that were crossed between, the Freedom Health movement, the Maha movement, and a lot of the traditional type medical things. And what we're going to have in Cleveland is, and when you look at our topics, we do cover a lot of the topics talked about today, and in this, everything from regenerative farming to healthcare sharing to eradicating, childhood cancer to healthy food initiatives to tackling sweeteners and pesticides and all of that type of stuff. And then we also will have 20 some breakout new technologies that cross the spectrum that come in and present and interact. And it's I always tell everybody our conferences are, if you're coming to look for, the $200,000 balloon display and the fancy decorations, that's not what's there. But I mean, the crossroads and the relationships. Every day I'm seeing, 2 or 3 people that connected at our last conference and are working to do something. They're coming back to us to try and bring resources and things to the table. So it's an incredible agenda. We've got some great panels and speakers and presenters. I mean, one of the comments people made about Washington was, I just came from a panel and 4 people on that panel are all traditionally keynotes. So it's really, we're a grassroots movement that's grown pretty fast. We have 1,100 ambassadors. We have an incredible driving leadership council. And in that we've got, 40 or 50 at least organizations that their memberships go into the millions. And so, we like to have a lot of motion that comes out of our program. So love you have to come to Cleveland. You'll hear from people like Dr. Oertle on one end of the spectrum. You hear from guys like Howard Vlieger on the other end of the spectrum, and everybody in between. And so yeah, I just like I said, if you want to help move the freedom, health, and the Maha movement, we'll do that. And one of the things we're going to talk about this conference is how we're advancing the ability to open up stem cells across the country. We'll have a continuation of our Lose Law program. And if Lose Law is successful, it'll allow people inside of Medicare and by default Medicaid, but Medicare for sure, to have options to choose alternate therapies besides what your local hospital or the medical industrial complex tells you have to do. It's landmark, groundbreaking stuff. So love to have you guys there.